Hello, my name is Sam Morshed, and I'll be speaking with you about pelvic ring injuries, initial management, and fixation strategies. Let's start with a case. This was a 50-year-old man who I met a few years ago while on call. He was sleeping under a truck when the truck got started and rolled over him. He presented to us in shock. He was hemodynamically unstable, hypothermic, and acidotic. Through the course of this presentation, I'm going to talk about ways in which we can begin to think about initial management all the way through definitive management of these pelvic ring injuries. The objectives of this talk are first and foremost going to be to get you to think about how to save a life. We're going to learn how to recognize hemodynamic instability and which patients are most likely at risk for it, talk about stopping the bleeding, and then move on to understanding injury patterns that will inform our ability to establish skeletal stability. Our first priority is to show up, have the appropriate equipment and gear and the appropriate mindset to anticipate and take care of these patients. Let's start with recognizing hemodynamic instability. The good news is that pelvic ring injuries associated with hemodynamic instability are actually quite rare. Unfortunately, the bad news is that they're lethal injuries, and these can result from bleeding, both arterial and venous, as well as many of the associated injuries that these patients often present with. We've known for a long time that we can recognize hemodynamic instability and suspect those patients at greatest risk for it by understanding the pattern of injury. This is a classic paper that looked at various forms of pelvic ring injuries and their associated venous and arterial bleeding sources. You can see that venous bleeding is much more common than arterial bleeding in all forms of these injuries, as categorized using the Young and Burgess classification, which we'll come back to in a little bit. You can see here that the most extreme variants of the lateral compression and anterior posterior compression variants, as well as the vertical shear injuries, are at greatest risk for presentation in shock. Now, we're going to talk a little bit about a stepwise approach or algorithmic approach to treating these injuries, but it's important to know that sometimes there's just not time, that you may be confronted with a patient with a large open pelvic ring injury who is just gushing blood, and you need to do something about it. I advise my residents to carry a set of pelvic packable Kerlix sponges like these. This was another patient that I treated during my fellowship, in which we had some pointed reduction clamps and could see the parasymphyseal ramus easily through the open pelvic wound, and were able to clamp this shut and restore hemodynamic instability in the emergency bay. Now, for situations that may not be quite that dramatic, we want to start with the ABCs. What does that mean? Well, this is a simultaneous evaluation resuscitation strategy that begins with looking at airway, breathing, and circulation. Circulation involves establishing adequate venous access for delivery of crystalloid and blood products. We also need to recognize and control hemorrhage, and that again means identifying a source. How do we identify that source? Well, traditionally, and really still presently, the mainstay may be obtaining appropriate radiographs. Perhaps you have the availability of an ultrasound for a focused abdominal sonography for trauma, or FAST scan, or peritoneal lavage. Selective CT may augment your evaluation as well. At our center, we've moved towards whole body CT with split dose IV contrast. CT findings include active extravasation, which would suggest an arterial source of bleeding, as well as retroperitoneal hematoma, which could indicate either arterial or venous sources of bleeding. Once we've identified the source, we need to obtain skeletal stability. Let me reemphasize that. Once a hemodynamically unstable patient is found to have an unstable pelvic ring disruption, skeletal stabilization is the priority. Now, you can go about establishing skeletal stability in a number of ways: an anti-shock iliosacral screw, a C-clamp, various applications of an external fixator, or a binder and sheet. All of these have been proven to be roughly equivalent in their efficacy, although you can see as we go from top to bottom here, the degree of difficulty decreases quite substantially. An anti-shock iliosacral screw can be obtained provided that you have access to an imaging suite and the patient is positioned on an appropriate radiolucent table. This also requires facility with the techniques for percutaneous insertion of iliosacral screws. Again, this kind of sits at the top level of that order of complexity and may not be available or achievable in many centers. A C-clamp is another device that can be inserted percutaneously in order to close pelvic volume. However, it's controversial as to the ease of its insertion and safe application. The external fixator is another really useful tool and can be applied using either iliac crest pins or a supra-acetabular pair of pins to close the pelvic volume. Again, the latter, or the anterior external fixator, applied by way of insertion of supra-acetabular pins, is a more powerful application, although it does often require the use of an image intensifier for safe application by way of these 3 fluoroscopic imaging views. A sheet or binder, while perhaps the most easy to apply, is actually quite efficacious. It prevents dislodgement of clots, reduces the pelvic volume, and allows reapposition of bleeding osseous surfaces. You can take a pelvic ring injury that is quite displaced, as this one is, with a large volume, particularly in the retroperitoneal space for accumulation of bleeding, and close this down with application of a pelvic sheet, remembering that the volume is proportional to the 3rd power of the radius. So any and all reduction in the radius of the true pelvis actually results in a very substantial closure of the space, the potential space into which a patient can bleed. So in summary, reducing pelvic volume and bleeding is critical. You need to do something. How you do it is less critical. Do what you're comfortable with and what resources you have at hand. Next comes the control of bleeding phase. Once we've established some skeletal stability, we can pursue other means of controlling bleeding. Angioembolization, if it is available at your center, can be quite effective in treating bleeding that is arterial in origin. Preperitoneal packing is another more recently popularized approach to controlling venous bleeding and arterial bleeding, for that matter, in the retroperitoneal space. It's useful when a patient is unstable despite arterial embolization. In summary, your algorithm should start with tending to ATLS protocol and the ABCs, identifying the pelvis as a source of hemodynamic instability and stabilizing the pelvis, followed by appropriate bleeding control measures. Now, Hopefully at this point we've saved a life, and we can begin to think about optimizing function for our patients through the understanding of the injury pattern and establishing definitive skeletal stability. How do we go about doing this? This is our patient now having undergone preperitoneal packing and application of a pelvic binder, which has achieved a nice indirect reduction, allowing the patient to survive through his first 24 to 48 hours of hospitalization for further resuscitation. So let's start with basic anatomy. The pelvis is comprised of the innominate bone, a fusion of the ilium, the ischium, and the pubis between 11 and 13 years of age. The sacrum is a triangular shaped bone of 4 to 5 fused vertebra into a single osseous mass. Ossification begins at 1, and fusion between the levels begins at 18 and ends at about 25 to 30 years of age. Interestingly, the fusion of the sacral body has been shown to be dependent on weight bearing. The innominate bone and the sacrum function together to transfer weight from the spinal column to the extremities while standing, or through the ischium while sitting. There's little bony stability to the relationship between these structures, and the posterior pelvic ring has been likened to a suspension bridge, where the sacrum is suspended between the two innominate bones through a series of ligaments. From posterior to anterior, the iliolumbar ligaments, posterior and anterior sacroiliac ligaments, the sacrospinous and sacrotuberous ligaments, and the ring is stabilized anteriorly through the symphyseal ligaments. Of course, one of the technical challenges of any operation in the pelvis is the concentration of nerves and vascular elements in close proximity to bone and the bony corridors. As with other areas of fracture care, various injuries lie on a spectrum of stability that is unitless and ultimately somewhat subjectively assessed. I like to think about anatomically describing a pelvic ring injury before trying to go any further in classifying the injury. If I were communicating this pelvic ring injury to one of my colleagues, I would start by telling them that I see a sacroiliac joint disruption on the right side with bilateral parasymphyseal ramus fractures in the front, a pubic root fracture on the left-hand side, and a sacroiliac joint fracture dislocation on the left side. Once we understand the anatomy and what's disrupted, we can begin to think about classifying these injuries. The mechanistic classification system introduced to us by Young and Burgess is the best predictor of resuscitation needs and associated injuries, as described earlier. While earlier work of Pinal and Tile laid the foundation for the mechanistic classification of pelvic ring injuries, the Tile classification system that was later adopted by the AO classified patients into bins of horizontal and vertical instability. The Tile A injuries do not involve structural or ligamentous disruptions to the pelvic ring. The Tile B injuries are horizontally unstable, but vertically stable due to the intact posterior ligamentous arch. And Tile C injuries are both horizontally unstable due to disruption of the posterior osteoligamentous structures, as well as vertically unstable. Remember that instability is a dynamic phenomenon, and it should really be thought about as such. Young and Burgess expanded on the early work of Pinal and Tile, subcategorizing the previously described force vectors into a continuum of injury and increasing instability. This continuum was based on the cadaveric experiments and the effects of ligament sectioning on observed stability. Mechanistic classification as I mentioned, is the best predictor of resuscitation needs and associated injuries. We can begin by thinking about the anterior-posterior pattern of injuries as sequentially disrupting the ligamentous stabilizing elements of the pelvis from front to back, with the APC3 variety resulting in both horizontal and vertical instability. The lateral compression variants start with a disruption of the anterior sacrum and progress to involve a windswept variant as LC3 injuries with, again, both horizontal and vertical instability. Finally, we have the vertical shear pattern of pelvic ring disruptions, which again result in both vertical and horizontal instability. It's important to recognize again that those patterns highlighted in yellow here demonstrate fractures that would be tile C type injuries with both horizontal and vertical instability. There's no controversy here about whether or not these injuries require stabilization, as they are complete injuries. The controversy really lies in determining those APC1 injuries that may actually be APC2 injuries with disruption of some degree of posterior ligamentous support, thereby requiring stabilization. Similarly, there's much controversy in discerning the difference between an LC1 injury, which is considered stable, from that pattern of lateral compression injury that results in instability. Now, we need to recognize then that that would require a through and through injury in the posterior portion of the pelvic ring, and that this would render the pelvis unstable enough to close down under dynamic stress or physiologic weight bearing. Again, the threshold for determining sufficient instability, as demonstrated either statically or dynamically, continues to be an area of investigation. Static imaging is the mainstay of initial imaging of these injuries and is comprised of anterior, posterior, inlet, and outlet imaging. The inlet image allows us to recognize horizontal instability, and the outlet image allows us to recognize vertical displacement and instability. CT scans are a valuable tool in further understanding the nuances of these injuries. But again, I would caution you to avoid using the CT as the only means of understanding pelvic ring injuries, and start again with plain radiographic evaluation. It's also really important to recognize what kinds of other forces may be acting on your static imaging, be it a plain radiograph or CT scan, as skeletal traction and a application of a pelvic binder or anti-shock sheet can result in significant differences and potentially reductions that ought to be recognized when trying to understand the pattern of instability. Sometimes we have radiographically obvious instability, as demonstrated here with this C-type pelvic ring injury. Other times, the instability is not so obvious and requires us to further interrogate the injury using a series of described dynamic stress maneuvers, including compression, which can take a lateral compression injury that looks relatively benign and demonstrates significant instability, or an opening pelvic maneuver, or assessment of vertical instability using a push-pull maneuver as described here. It's been noted that up to 50% of APC injuries that look stable actually open up to a sufficient degree to suggest anterior sacroiliac ligament disruption necessitating treatment. And many of those that look as though they are APC2 type injuries, when further interrogated in terms of vertical instability, have been shown to actually displace in the vertical plane. Similarly, we have many lateral compression injuries that appear benign, however, with a compressive stress maneuver will show sufficient overlap to suggest horizontal plane instability that would benefit from operative treatment. This is perhaps a little bit more of a nuanced diagram that shows or suggests a iterative approach to understanding pelvic ring injury, starting with evaluation without any sort of fixation of horizontal plane instability and sequential examination after fixation, starting in the posterior pelvis and moving anteriorly as required to sufficiently stabilize lateral compression variant injuries. When we're planning our approach, it's really important to understand exactly what kinds of surgical incisions have already been placed on our patient, any sort of diversions of the gastrointestinal tract, and catheters or drains that may interfere with safe incisions for pelvic ring stabilization. The Morel-Lavallée or internal degloving type of injury is really important to recognize, as demonstrated in the patient case that I presented at the very beginning. Here, after placing a posterior approach, we could see how significant the degloving injury was. And of course, these vast areas of potential space are going to increase the risk substantially of wound healing complications and infection, and should be treated accordingly. How about when? When should we go about trying to operate on a patient like our patient here? Well, work by Heather Valier and her group at Metro Health have demonstrated some useful thresholds of resuscitation for us to guide our decision-making around optimum treatment time. We really try to aggressively resuscitate our patients within the first 24 to 36 hours to achieve these threshold values of acidosis and pH. So long as you can achieve these numbers, it is safe to proceed, and it is in your patient's best interest to do so as expeditiously as possible. This is our patient 48 hours after presentation. You can see a nice resolution of his acidosis with a lactate value of 2. And the image here demonstrates removal of the pelvic packing, application of a binder, and skeletal traction on the left side. This patient is now ready for operative management. Let's talk a little bit about reduction tactics. I think it's important to understand the power of both indirect and direct reduction maneuvers in managing these kinds of injuries. Again, we started with a very hemodynamically unstable patient and were able to achieve stability by way of indirect approaches and application of a pelvic binder or anti-shock sheet in this patient's case. Skeletal traction is another very useful tool in indirectly reducing pelvic ring injuries, and I often use this in preparation with particularly C-type injuries that result in vertical instability. And this can be taken into the operating room and continuously used during surgery in order to allow for sufficient reduction. The use of external fixators is also incredibly powerful in the operating room. It does require, in many cases, an intact posterior hinge or posterior sacroiliac ligaments in order to treat these injuries most effectively. Placement of supra-acetabular pins using a combination of outlet obturator, inlet obturator, and iliac oblique views allows for safe application of these pins and allows for a vector of reduction in the horizontal plane that is superior. You can take an injury with gross diastasis through a pubic fracture on the left-hand side and sacroiliac dislocation on the right side and achieve an excellent indirect reduction of the pelvic ring. Anterior external fixation actually can be and has been shown to be effective as a definitive treatment for B-type horizontally unstable pelvic ring injuries. One can also use a iliac crest or gluteus medius Pilar pin as demonstrated here in using insertion guided by an outlet obturator and iliac oblique image with fluoroscopy during surgery. When you don't have a portal or a supra-acetabular pin may be otherwise contraindicated, this is my second choice for pin placement for external fixation, either as a definitive means of treatment of the anterior pelvic ring injury or as a useful adjuvant during surgery. One can use an external fixator to assist in the reduction of different kinds of pelvic ring injuries, such as this lateral compression injury, where a universal distractor, a form of external fixation, was used to restore the horizontal displacement, allowing for reduction and placement of definitive fixation using percutaneous iliosacral screws and a pubic ramus screw inserted in a retrograde fashion. How about direct reduction? There's three surgical approaches that I most commonly use for management of pelvic ring injuries. The anterior approach, this is performed using a Pfannenstiel or vertical approach, and it is the same as the anterior intrapelvic approach that has been recently popularized for management of acetabular fractures as well. The lateral window of the ilioinguinal, which allows access to the ilium and the anterior sacroiliac joint, and the posterior paramedian approach, which allows access of the posterior ilium, SI joint, and sacrum. How about tools? Well, an assortment of clamps, joysticks, and pushing and pulling instruments are really vital for direct reductions. In terms of hardware, pelvic reconstruction plates and screws, as well as large diameter screws for open and percutaneous application will suffice. The anterior approach involves reducing the anterior portion of the pelvic ring. And this is importantly a powerful means of indirect reduction of the posterior pelvic ring, which, as we described earlier, is really where the structural integrity of the pelvis is determined. So again, closing, reducing, and plating the symphysis is actually a powerful means of making sure that you're closing the posterior aspect of the pelvic ring. Remember to use a multi-hole plate for symphyseal plating. And remember that if you're treating an APC2 injury, and certainly if you're treating an APC3 type injury, that fixation of the anterior pelvic ring is not enough. Now, it is important to note that if you're treating these injuries in a environment where the risk of a posterior approach is great, or you may not have the implants that are required, that this may be debated. However, it has been shown that APC2 type injuries that received only anterior plate fixation were more likely to displace and result in malunions long term. Therefore, I recommend compressing and holding the back, and this again can be done by means of percutaneously placed iliosacral screws or application of plating of the reduction and plating of the sacroiliac joint by way of a lateral window. Lateral window is particularly useful, as I've mentioned, for reduction and instrumentation of sacroiliac joint disruptions. It can be very useful for complete or C-type injuries where the posterior SI ligaments no longer afford a hinge that allows reduction in the front to indirectly reduce or close the posterior pelvic ring. The injury demonstrated here is a vertical shear with complete SI disruption. Here I was able to clamp the sacroiliac joint and reduce it by way of a lateral window, allowing for placement of a iliosacral screw to hold the anatomic reduction of the SI joint. I could have easily have plated the SI joint in this case as well to achieve a similar result. How about the posterior approach? This is perhaps the least familiar approach to many surgeons who treat pelvic and acetabular injuries, but is important to have in your toolbox should you encounter injuries like the one I've just demonstrated, where anterior fixation is not going to do much to afford a posterior ring reduction. In this patient of ours, returning again to the patient that I presented at the very beginning of this presentation with the open pelvic ring injury, I placed the patient prone, performed a paramedian open approach to the sacroiliac joint on the left side, here reversed because imaging is obtained with the patient in a prone position, and sequentially reduced both SI joints, followed by definitive internal fixation. Sufficient stability requires reduction and stabilization of the posterior pelvic ring, as seen in this example. Here, following completion of my instrumentation of the posterior pelvic ring after anatomically reducing all of the fractures and dislocations, a compressive stress exam and push-pull maneuver demonstrated no further vertical or horizontal instability. And here's the result demonstrated with outlet and inlet pelvic imaging. So remember, static, less than 1 centimeter displaced lateral compression 1 and dynamic stress confirmed anterior posterior compression 1 injuries are stable injuries and can weight bear immediately. C-type pelvic ring injuries resulting in both vertical and horizontal plane displacement are unstable and benefit from surgical stabilization. It is these 61B type patterns, again, the dynamically stressed confirmed LC2s and APC2 injuries that may benefit from operative stabilization. I hope that through the course of this presentation, you've learned a couple of maneuvers that will be truly life-saving by way of recognizing hemodynamic instability and taking the measures necessary to stop bleeding. This allows our patient to survive long enough for us to understand the mechanism of instability and apply the techniques that we've learned here to establish definitive pelvic ring stabilization to ultimately optimize function. Operative reduction and fixation really should happen as soon as your patient has been resuscitated, and really requires that you understand both the mechanism and pattern of instability in planning your surgical approach. Prioritize posterior ring reduction and stabilization, as that provides for durable maintenance of reduction. It's important for you, as you build your learning curve in management of these injuries, that you master both indirect and direct means of reduction and internal fixation. And remember the utility of iterative dynamic stress examination to guide the extent of treatment required. Thank you very much for your attention, and I look forward to hearing from you if any questions should come about as to the content of this presentation. You can find further resources on our YouTube page and the IGOT portal. Goodbye.